what is it? Intraoperative cardiac arrest can be defined as a sudden cessation of cardiac output and effective circulation resulting from the complete absence of or presence of a markedly irregular cardiac rhythm. This can occur at any time during the perioperative period. How do we get there? The history lies with anesthesia. The inherent risk of cardiac arrest played a hand in anesthesia developing as an acknowledged medical specialty. After the successful public introduction of ether and chloroform as anesthetics for painless surgery, John Snow published a review of 50 cases of fatal chloroform administration in mostly young, healthy individuals booked for minor surgical procedures. Initially, cardiac arrest during surgery seemed to be specifically related to the use of general anesthesia. However, with increased use of regional blocks, fatal outcomes were also connected with physiological causes such as loss of sympathetic reflexes, drug toxicity, convulsions, and early or delayed hypoxia. Cardiac arrest related to airway management has decreased over time as a result of enhanced monitoring, producing a plethora of data available from our machines, such as pulse oximetry, capnography, and tidal measurements, and disconnection pressure alarms. Management of difficult airways has improved through new airway devices, tools, and increased awareness through distribution of guidelines and algorithms. However, repeated laryngoscopic attempts increased cardiac arrest by 10%. Predicting difficult intubation, the use of ASA guidelines, and awake intubation techniques can offset this risk. We have also made gains with institutional improvements, including post-operative surveillance and PACU. Organizational and human factors, along with presence, experience, and carefulness of staff, have influenced mortality. However, increased demand of anesthetic support during diagnostic and interventional procedures outside the OR has created new hazards. These areas are less controlled and monitored compared to well-equipped and staffed ORs. Risk factors. Our surgical population has dramatically changed through time. On one hand, patients are older, have numerous and severe comorbidities, and procedures have become more complex. On the other hand, the incidence of perioperative cardiac arrest is higher in children, especially newborns and infants. Infants account for almost 50% of all pediatric cardiac arrests, with the highest numbers between 1 and 5 months, with the mortality rate of 27%. Other risks include ASA class 3 and higher, including PEDS patients, hypovolemia from blood loss, hyperkalemia from transfusion, and respiratory causes linked to airway obstruction from laryngospasm. Cardiac arrest can go hand in hand with anesthesia, but it does not necessarily cause it. The more likely culprit is the patient's pre-existing conditions, such as cardiovascular disease or severe trauma. However, half of anesthetic management related events are caused by airway or ventilatory problems, followed by medication accidents and infusion or transfusion mishaps. Anesthesia-related cardiac arrests can be caused by human error through organizational, structural, educational, or workplace failures. Awareness of the issue and sensitivity to human factors is growing, defining soft core skills such as behavior and learning from others. Surgical factors leading to cardiac arrest have declined significantly over the years. These fatal incidents can be divided into 4 categories, ranked from most to least common. Preoperative complications at 65%, surgical procedures, primarily excessive bleeding at 24%, intraoperative pathological events such as MI, PE, and severe arrhythmias are 9%, and anesthetic management is only at 2%. Ortho. Intraoperative arrests are rare events during orthopedic surgery. Although infrequent, they have a mortality rate as high as 35%. Intraoperative arrests occur more often in spinal surgery, IM nailing, and cemented endoprosthetic reconstruction, which is replacing part of a long bone, and it looks like this. So anytime you're doing some sort of reconstruction case where you're replacing part of the long bones, high risk.
Is it because it's like a high risk for PE and then it causes the cardiac? Yeah. Okay.
When instrumenting the canal and implications of reaming and cement application on a patient's physiology should be considered. Reaming and nail insertion was a trigger event for 50% of arrests during tibial and femoral IM nailing. PE is the most common cause, good job, of arrest in orthopedics,
Count it.
resulting from a thrombo, venous gas, or fat emboli. Other etiologies include bone cement implantation syndrome, MI, anaphylaxis, hemorrhagic shock, vasovagal response, cardiopulmonary collapse, and complete AV block. PEA and asystole are common rhythms of arrest. with VFib being less likely. Survival rates are quite poor if return to spontaneous circulation is greater than 10 minutes. Even if the patient with intraoperative arrest survives the initial event, they are at high risk for several associated complications. Understandably, case abortion with rapid closure and a delayed return to the OR increases infection rates. Furthermore, post-cardiac arrest syndrome occurs as a result of total body ischemia followed by reperfusion. This physiologic process results in organ dysfunction characterized by post-anoxic brain injury, cardiovascular impairment, and systemic inflammation. Roughly half of intraoperative cardiac arrests occur during induction or end of procedure events such as closure, extubation, and bed transfers. This highlights the importance of staying calm and quiet during induction and extubation, particularly with medically complex or critically ill patients. In these situations, successful extubation is a critical component of surgery. Endoscopy. Life-threatening events can occur in endoscopy. GI bleeds such as hematemesis and melena are the most common culprits. Patients can develop respiratory insufficiency, decreased blood pressure, and cardiac arrhythmia linked to aggravation of their underlying disease. Although most of these conditions are detected during endoscopy, 1/3 occur pre and post procedure. GI bleed was a single independent risk factor for mortality in endoscopy. Life-threatening situations requiring CPR can occur before, during, and after endoscopy, and greater attention should be paid when endoscopy is performed for GI bleed. What now? On a good note, cardiac arrest during anesthesia occurs in an ideal setting for optimal quality resuscitation. In an OR setting, they are always observed, patients are monitored, intravenous access is established, and oxygen, emergency drugs, and defibrillators are immediately available. On the flip side, as individual practitioners rarely encounter cardiac arrest, this may influence the speed of diagnosis and the consistency of appropriate management. If a potentially reversible cause for cardiac arrest is presumed, aggressive and prolonged resuscitation efforts must be considered. Perioperative cardiac arrest is a rare event, and anesthesia-related cardiac arrest is associated with favorable outcomes, some 80%. So that's great. Calling a code. Code blue. Everybody know where to find the document?
The document?
Yes,
On the
this
dashboard.
document.
Didn't you guys say there's emergency binder up front?
Right there, beside Tori's desk. Beside Tori's desk. I try to say that in one word. Okay.
Did you talk?
I did know.
Did you talk about laparoscopy?
Right, like
It didn't
increasing
come
the
up.
pressures in the belly?
I have had a 22-year-old healthy patient come in for lap chole
Mm-hmm.
that I went out of the room in Maryland to get something and came back in and they were doing chest compressions. He coded when they inflated the abdomen.
I wonder if you had some sort of underlying thing
Wow.
going on that nobody
Oh,
knew
for
about.
sure.
Exactly.
For sure.
AAA.
So just because you think they're young, healthy, that interpressure in the abdomen can trigger.
Well, and we've had it where surgeons are like, we need to decrease, or the anesthesia
Yes.
says we need
Yeah.
to decrease pressure
Mhm.
because of the,
Yeah.
um,
Shifting your fluid.
Yeah.
yeah,
Probably.
and the, what is it, when they're not, when they're bucking the vent, what is that called?
Bucking the vent.
Yeah.
Technical term.
Yeah, that, because of the pressures and stuff, but anyways, yeah.
All right. I'm just gonna go through the highlights on the code blue document, the important things, okay, to remember in an emergency. So how to call a code blue? There's a priority sequence. So the best way is to press the code blue button, and we already talked about. Everybody should know where one is. If you don't and didn't want to admit it, please look for one in each room. The second one, you dial 76222 to get the switchboard, and then you say code blue. Give the building name, the level, department, and room number. Is anybody going to remember to do that?
No.
Yeah. You could also press. We don't have one of those.
Do we
It's the
have
red
that?
call for help buttons. Do we
We
have
have one
that?
in par.
We do, yeah.
A red button?
Yeah.
I thought they just
Isn't
have
it
the
red?
cold. They have the blue ones at the head of the bed. Is there an extra one?
They're like buttons in the, I've seen them in.
Did you say,
Yeah.
call blue? Did you
Um,
say, call Myra?
I would never suggest that. Okay, and then number 4 was use whatever means are necessary to help call for help, even if you have to leave the patient and come back, which should be non-existent here. if you wanna use a voice there, press the button, and call the code to connect to switchboard.
See,
Okay?
that's why I've been trying to call you.
But
I'm
that,
like,
that's
did
the
you say-
last one, don't do that.
Can you just double
Hit
click?
the button.
You could
And
broadcast.
broadcast to the
Yeah.
whole facility.
You could, like, if it's the middle of the night and you're having a hell of a time,
Yeah.
just broadcast.
Whatever method.
Not like voice hairs are working right now.
No,
Perfect.
Yeah.
that's true.
All right. Page 1. Page 2. Staff roles and responsibilities. All staff providing direct patient care must ensure appropriate PPE is worn. Protect yourself first, okay? Initiate CPR. This is most likely going to be the scrub nurse because you're sterile and you still want to maintain your sterile field if at all possible. Okay? Sometimes when the co-team gets here though, it becomes a little muddled.
But if you're with Dr. Chong, he's very helpful.
Yeah.
Awesome. I'd love to
Gets right
see
in
that.
there.
Yes,
Okay.
he was putting a femoral line in and everything. He was just right in there.
A couple other things. Anesthesia should be turning on their suction. Well, they'll have their suction and their tonsil suction near the patient's head because it's already there as a safety feature. Make sure you have the patient's chart. One staff member needs to be available to direct the code team. So that's usually the PCC to give them the location. And then, they need somebody to give history. And then this all comes to certain roles here, which if you're on the ward, it doesn't. It's whoever's like there. You know what I mean? So anesthesia and the circulator need to provide history to the code team. Everybody know who's responsible for the OR cart?
The what?
PAR grabs the code cart on the way through.
Oh.
And then they're also responsible for keeping it stocked. So if anybody touches it, please tell them.
Same with difficult intubation, by the way. Sorry, that's on my huddle notes.
That's it.
Tell PAR, they stock everything for you.
Well, it's just really important because there's a lot of stuff that isn't just readily available. Like that's the important thing is that we have to get some sort of things ordered in and
Takes a bit.
it takes a bit,
Yeah.
so.
Or we have extra stock, which is thrown away
Yep.
routinely. Bit of a waste. All right. Did all that. Oh, keep in mind, anesthesia should trigger. Holy. That was one word. Anesthesia should trigger the code call. If you are concerned, please speak up. If you can see that they're struggling and they're panicking, please say something. Okay? Okay. What do we need to do? From ORNAC, advanced directives and DNR orders should outline parameters for resuscitation efforts in which patients may or may not want CPR in the event of a cardiac arrest during surgery. During the time out, ensure the patient's wishes are known and followed by the team.
That's your most form here.
Mm-hmm.
Everybody has one. So the-
True story.
And I've also heard very differing opinions on this. I've heard some people say that if they're coming into the OR, the patient is accepting to have all measures taken.
No.
That's
No.
that's what I've heard,
Yeah.
and I was like, I'm questioning this. Like, this is
No.
not.
So this is a no.
So, yeah,
So most stands then.
yeah.
Most stands.
Okay.
Yeah.
They're allowing intubation for the
So
procedure.
surgical intervention isn't always life-saving. It can be a quality of life type kind of procedure. So if you've got a broken hip that's 89 that's going in and is a most of M2, they can still accept surgical intervention for comfort.
But still don't.
But if they code, hands out.
I think a lot of the doctors don't
Know that.
Yeah.
They live here, we're
Yeah.
they've accepted to have.
Yeah.
So I don't know if that needs.
That would need to be a
rediscussed.
conversation that they have with the team as well then.
Yeah.
Yeah.
Absolutely.
So still bring it up.
Yeah.
Okay?
So if they have
Gross.
the most form in the
Wipe
chart.
that.
I'll wipe it after.
They
You're
should.
gonna put that on your face.
Absolutely.
You have right beside you.
I have the immune system
Right
of
beside
a
you.
mule.
Yeah, sounds like it.
Not how I got this way.
Sorry.
So Myra, if there's a most system in the chart, we should put that in with our
you should add that to your timeout.
Yeah.
Yeah.
Mm-hmm.
Oh, yeah.
Okay.
That's a good idea. I didn't know that. I just assumed we assumed
Yeah, I
OR,
don't-
full code.
Yeah,
They came in, they were full code, yeah.
Yeah, that's old school, and then they had to redo their most forms after surgery.
It was a curse.
All right, be familiar with the location of supplies and equipment needed during cardiac arrest. Most of ours is, funny, cause it's not about the OR specifically, most of our stuff, like safety stuff, is all near the anesthetic cart. It's also important if you see something missing, to put it back on there, like an ambu bag. We did go through like a rash of days where like there wasn't any of them on the anesthetic carts.
Oh.
Yeah. Circulating rules may include but are not limited to activating the emergency alarm and initiating the code blue, recording the time of the arrest, repositioning the patient as required to perform CPR, performing CPR until additional help arrives, directing available team members to control traffic, completing counts if able with the scrub nurse, and documenting all events of the arrest. Scrub rules may include but are not limited to covering the incision with sterile drapes, if required, protecting the integrity of the sterile field, tracking sponges, needles, and instruments, completing closing counts if able, and assisting with chest compressions. Resuscitation efforts become the primary focus for all team members. The scrub nurse may be required to break scrub to assist with resuscitation efforts, depending on human resource availability and clinical assessment, including the stage of the surgery. All right, debrief. If resuscitation is unsuccessful, supportive care must be provided to the family in the immediate post-op period. This should involve spiritual care and administrative personnel. Integrating the spiritual needs and preferences of the family enables them to cope with the event and decision-making. Healthcare chaplains are experienced and have pivotal roles in supporting family and staff after crisis situations. Critical incident management and debriefing sessions should include all team members involved in the cardiac arrest. This gives team members time to express their feelings and debrief the situation. Improvement processes can also be identified and discussed at the time. Additional supportive resources such as counseling or bereavement services are available to team members. It is important to have a safe, non-threatening environment to debrief after a cardiac arrest event. This allows for improving knowledge and skills through meaningful reflection regardless of the outcome. Is anybody gone to a debrief? How did you feel about it after?
Mine was big. There were, like, it was pretty much every department